Hello, dear colleagues. Hello, dear friends. I am privileged and honored to open this very first part of this meeting in front of such an distinguished audience. And because of that, owe my great gratitude to Sylvia and Ines for inviting me. At the same time, I have to apologize you for not being with you physically in the beautiful city of Osijek due to the medical reasons. And here I'll try to give you a solid basis for further discussion. So let's start. So my duty is to give you some introduction to acromegaly modalities and treatment goals. And as you all know, acromegaly is a rare hormonal disorder with an incidence of 2 to 11 cases per million per year. So according to this, we can expect in a country like Croatia to have around 30 cases per year. Taking this into account, we can expect the prevalence of around 4,600 cases per million worldwide, or 28 to 137 cases per million per year. So looking from this perspective, this is not so rare hormonal disorder. We can expect also several thousand cases in a prevalence per year, so it's not so small number. As you can see here on the slide, men and women are equally affected, and of course, expectedly, pituitary adenoma is the cause of this state in over than 95% of cases. Talking about mechanism of disease in acromegaly, this disease is of course a consequence of excessive circulating levels of growth hormone and insulin-like growth hormone. In the same time, somatostatin and growth hormone releasing hormone are trying to control GH secretion, but these signals are overwhelmed in acromegaly, and we have acromegalic features as a consequence of this. The manifestations of acromegaly are diverse, and because of that, of course, difficult to note, to notice, and to put all together always in a final diagnosis of acromegaly. Of course, when we have very expressed some manifestation like enlarged of the jaw or these supraorbital arcs, it's easy to establish a diagnosis. But there are many cases in which we have very, very difficult establishment of diagnosis. We can list here headaches and visual field defects, sleep apnea, which is a feature that is recognized in the last 2 decades, and it's a lot spoken about that. We have hepatomegaly, we have gastrointestinal manifestations, sexual dysfunction, enlarged hands, osteoarticular conditions, feet, and changes in facial features. But the most important features of acromegaly are cardiovascular disorders, as the majority of patients with acromegaly finally are going to die because of cardiovascular disorders, especially cardiomyopathy with hypertrophy and the interstitial fibrosis of the tissue. These states are those states that are finally going to cause the death of our patients, and metabolic disorders are those states which are going to make this possible, especially like diabetes mellitus in the first place. Diagnosis of acromegaly is includes broad range of clinical manifestations, making sometimes, especially the diagnosis of acromegaly very challenging. You can see here on this slide occurrence of common clinical manifestations. Sometimes we can notice that these symptoms they're present even more than 10 years before the diagnosis is established. So the recommendations for diagnosis of acromegaly includes measuring of IGF-1 if typical clinical manifestations of acromegaly are present, but if no typical manifestations, but several associated conditions like sleep apnea or diabetes type 2, we have to rule out acromegaly in a patient by measuring IGF-1. If the measurements of IGF-1 are elevated or equivocal, we have to confirm diagnosis by OGTT, trying to achieve the lack of suppression of GH to lower than 1 microgram. Of course, after we have established the diagnosis biochemically, we can perform the imaging. In this case, of course, the MRI is a preferred imaging technique to confirm diagnosis and visualize tumor size and appearance. Talking about treatment's goal, and this is something that this topic and subject that you are going to talk today the most, you're in OSIC. We can three main goals. The first is to control biochemical outcomes. The second one is to reduce tumor size and prevent the further tumor growth. And finally, we have to reduce symptoms and comorbidities to improve clinical outcomes. So, talking about biochemical control, the main target is to normalize IGF-1 levels and GH to achieve GH below 1 microgram per liter, as this biochemical control is associated with reduced mortality. And talking about that, you'll see in another slide. In present days, we can almost normalize the lifespan of these patients with modern therapy we have on this position right now. But on this slide, you can see that normalizing of GH and IGF, both of these hormones, can be attributed to decrease the risk of morbidity and mortality the most. So the biochemical control in our patients is the crucial one. The major point is to achieve biochemical control. So mortality is almost reduced to nothing, almost nothing, because the studies published after the 2008 almost show the normalizing of mortalities in comparison to the general population. You can see here the differences between the mortality within the studies published before in 2008 and after that year. And the key difference is the use of the modern drugs, somatostatin analogs, which you are going to talk about later. So the control of tumor size is the second most important goal, and of course the larger tumors are associated with poor clinical outcomes, which is of course expected. Here you can see that microadenomas are often achieving very high remission rates after surgery, of course, and it's almost linearly depicted here how with the raise of the diameter of the tumor, remission rate is decreasing. So the volume reduction of 20 to 25% is something that is considered significant. If we can reduce it more, as better. And also we have to say that pre-surgery treatment with somatostatin analogs can reduce tumor size, and by that it can improve early remission rates after the surgery. On this slide we can see that the relapse is always connected, associated with younger age, with the higher growth hormone, and with higher nadir of growth hormone, and of course with the size of the tumor itself. Finally, in treatment of our patients, we have to reduce signs and symptoms to improve quality of life of these patients, comorbidities, and at the end of the story to decrease early mortality. The most important goals in this term is to control hypertension, cardiac hypertrophy, diabetes and metabolic disturbances, sleep apnea, and osteopathy. To assess the outcomes and to follow these patients, the tools that are invented can be used, like SAGIT or Acromegaly. And also we have some quality of life questionnaires that can also be used, but this is not so precise mechanism to control our patients. Here we have this is a slide which shows us the guidelines and recommendations for the individualized approach in patients with acromegaly. So the transphemoidal surgery is something that is on the first place, and if the remission is achieved, then we have to follow the IGF-1 and GH levels annually. Of course, we can perform OGTT if necessary, and of course, in specified timetable, we have to perform MRI, of course. But if we have persistent disease, if we have the patients with, who are the poor surgical candidate and whose tumors are unresectable from different reasons, we have to think about medications. And today we mostly use somatostatin analogs. We are going to show the three major somatostatin analogs. We can use, of course, the dopamine antagonist like cabergoline or bromocriptine, and also the GH antagonist. And if we do not achieve the result with one of them, we can combine them, we can interchange them, and if still no result, we can consider the stereotactic radiotherapy. Here we have depicted the action of somatostatin analogs on somatostatin receptors. We do have 5 different types of somatostatin receptors, and different somatostatin analogs have the influence on different receptors in a different strength. So as you can see here, octreotide can act mostly on SSTR2, and lanreotide is also a drug with a major effect on type 2, but pasireotide mostly acts on type 5. And here we have the fact that GH secreting adenomas predominantly express type 2 and type 5 receptors. So with the combinations and appropriate selection of SSI, we are trying to achieve the optimal result in each individual patient. So this is very important information. The close enough is good enough is a phrase that is not of use in the treatment of acromegaly, because even mildly elevated levels of growth hormone or IGF-1 can lead to cardiovascular, respiratory, endocrine, and metabolic diseases as a consequence of acromegaly. So we have to treat these patients very aggressively to achieve full biochemical control. This is the major target of this treatment. Also, the tumor volume is, as we already said, the one of the major goals of the treatment. So the effects on the tumor size is also something that is of huge importance. Activation of these mentioned somatostatin receptors reduces the GH release and increases the apoptosis of the tumor cells, and of course decrease the cell growth and proliferation. This is the final impact of the activation of SSTRs, or somatostatin receptors. So when we are trying to achieve the remission, although the biochemical remission is the primary assessment of treatment outcome, it's not the only treatment in acromegaly. In all cases, these biochemical findings have to be integrated within the clinical context of acromegaly signs and symptoms, and they have to include all three main goals, especially enhancing the last one. So the influence on the quality of life, the signs and symptoms that are following these patients. So I hope and I believe that this introductory is going to be a good basis for your fruitful discussion, and I wish you a very pleasant stay in a beautiful city of Osijek, and I send you huge regards from at least as beautiful city of Split. Best regards from me.